Hello and welcome to our viewers in the United States and Europe. I am Katja Donovan, Chief Officer of 1014, and it's my pleasure to welcome you to today's episode in our series titled Resilience and Adaptation, which is organized and hosted by the American Council on Germany and 1014.
And I'm Steve Sokol, the president of the ACG. COVID-19 cases are surging again in Europe and the United States. As we head into the holiday season, public health officials, healthcare workers, and hospital administrators are already grappling with the challenges of providing care to patients. As we brace for the coming weeks and months, what are the prospects for hospitals in Germany and the United States? And what do hospitals and the public health systems in general need to quickly respond to future pandemics? How can we ensure that our societies will be better equipped to handle similar outbreaks in the years to come?
Here with us to talk about this are Dr. David Reich and Professor Dr. Eckhard Nagel. Thank you both for joining us.
Pleasure to be here. Thank you so much.
Thank you.
Thank you.
Nice to have you. Professor Dr. Eckhard Nagel is the Managing Director of the Institute for Medical Management and Health Science at the University of Bayreuth. From 2001 to 2010, he was head of the Transplantation Center and head physician in the General Surgery Department at the Klinikum Augsburg and professor at the University of Bayreuth. From 2010 to 15, Dr. Nagel was medical director and chairman of the executive board at the University Hospital Essen. Dr. Nagel was a member of the German Ethics Council from 2008 to 16. Since 2015, he has been a member of the University Council of Coburg University of Applied Sciences and member of the supervisory board of Charité Universitätsmedizin Berlin. Since 2018, he has been the German president of the Chinese-German Friendship Hospital of the Tongji Clinic, Wuhan. Dr. David Reich is the Horace W. Goldsmith Professor of Anesthesiology. He has been president and chief operating officer of the Mount Sinai Hospital and president of Mount Sinai Queens, both part of the Mount Sinai Health System since 2013. Dr. Reich was chair of the Department of Anesthesiology from July 2004 through March 2014, and also served as president of the medical board in 2011 and 12. But before we get started, we would like to remind everyone that the ACG and 1014 are independent, non-partisan organizations. So the views expressed during these conversations are those of the two experts. Also, if you would like to ask questions, please use the chat function on Zoom. You can also send an email to steve@sokol@acgusa.org. We will forward your questions into the conversation.
COVID-19 hospitalizations in the US just surpassed 85,000 in a single day, setting another record. This is the 14th straight day of increases. And we're seeing an increase in cases and in hospitalizations in Europe as well. As the number of cases and hospitalizations surges in both Europe and the United States, are hospitals prepared for this uptick? That's what we want to start our conversation with. Dr. Reich, let's start with you. We'd love to hear how Mount Sinai is responding, but also your observations about US hospitals in general and the response to the uptick in cases.
Let me begin by saying that we're in a very different situation now than we were in the early part of March, when in New York City specifically, we really had no idea of the tidal wave that was approaching us. The absence at that time of any form of testing and frankly, our retrospective research demonstrating on samples saved up at Mount Sinai that COVID was clearly circulating already in New York in early February, unbeknownst to the population, created a circumstance where without any preparation really nationally, there were massive demands for critical care services, ventilators, and PPE that overwhelmed a supply chain that had heavy international dependencies. So the difference between March and November, almost December now, is really almost night and day. in that the health system has had time to think about what resources are necessary to be successful. And frankly, the medical profession has, with variable degrees of success, engaged with public health officials at the local and the state and the federal level to advocate strongly that hospitals are in many ways the passive receiving end of failures of public health policy that fail to break the chain of spread with public health measures in advance of good therapeutics. And our therapeutics are probably helping a little bit in that the first wave mortality was 20% and now our mortality was 5.1% post-July. But still, it's a very deadly disease, and hospitals have very little control about who needs hospitalization. That is where I think our position as content experts and advocates comes in.
As reported a couple days ago in the New York Times, in the spring, there was a massive shortage of ventilators, and that doesn't seem to be a problem this fall, as you just said. But what I was reading that struck me is that there are enough devices, but there's a shortage of experienced practitioners, whether it's respiratory therapists, pulmonologists, critical care doctors with the training to operate the machinery and provide round-the-clock care. How serious do you think that shortage is?
One of the biggest challenges of a surge that puts a demand on critical care services is that it's just not something that has a lot of reserve. So training a respiratory therapist and intensive care physician, what we call them U.S. advanced practice providers, meaning nurse practitioners and physician's assistants, and probably most of all critical care nursing. These are very challenging for us. In fact, in a normal time, one of my biggest problems is just maintaining an adequate number of critical care nurses, because many of them go on to other opportunities in the US, such as becoming a nurse practitioner or perhaps training in nurse anesthesia, which is a very lucrative profession for nurses in the US. So if you take an already borderline short-staffed resource, and then you amplify the need for critical care services, even without intubations, because many patients with COVID may be in a critical care unit, but now being treated in the prone position or with non-invasive ventilation, just speaking as an anesthesiologist, critical care at this point in COVID does not always mean ventilator.
Thank you. Professor Dr. Nagel, Dr. Rich was just talking about the difference between night and day in the US when comparing March and November, December. There's been a big difference in Germany when comparing March with November, December. During the first wave of the coronavirus crisis, Germany was a model for the rest of Europe and indeed the rest of the world. But from what we've been reading here in the US, it looks as though Germany is now struggling with more severe infections than at any other point during the pandemic. How have you been handling the uptick, and how have German hospitals been handling the uptick as a whole?
I totally agree with Dr. Rich that we have different times, and that you have to really differentiate between March and the period now. And first of all, and that was Dr. Rich already said, is that we have a much better understanding of the disease than we used to have it, and that, for example, the mortality rates on intensive care units are also declining in Germany as well as in the US. Now, that makes a big difference. When we are talking about situation that we have been a model for the world, how we cope with the situation, I don't think that we have such a different situation today, but we feel different, and the public awareness is different. So I think we really have to differentiate that too. The hospitals in Germany are prepared for an uptick. There are currently different structural and legislative initiatives which increase the emergency capacity in German hospitals over the last 6 months. And this includes, and that is a problem in our discussion, the postponement of elective operations and the creation of new intensive care beds with ventilation facilities. Also what we centrally did is that we financially compensated to keep these capacities up, and that people in hospitals, we as a hospital, receive a bonus for each additional created intensive care bed. So that has changed the situation in a positive way, one would think, in the first place. But nevertheless, we have a smaller amount of intensive care beds today than we used to have in July. And we already discussed that problem here too, regarding a shortage of experts in the hospitals. We do actually have the facilities, but we have a shortage at the personnel and the expert status to keep up with these facilities. And that really makes a problem during time, because when everyone was able to even go to the hospital to take part in an emergency situation, after 10 months, this is overdone. And what we already had last year and the year before, that we have a shortage of experts in our hospitals, that now really comes to a point where this shortage makes it difficult to keep up with the rising number of patients. In general, the treatment has not changed fundamentally. The efforts are still being made that to treat as many patients as possible in outpatient settings, and only the severe cases are treated in the best possible way under intensive care conditions. And in conclusion, we have a national intensive care registry. With this registry, we can report in which area there is a shortage to look forward. For example, in Berlin, we now have reached the capacity limits and will do so in the coming weeks. And now by our registry, it is possible to identify such bottlenecks at an early stage and distribute the patients to neighboring city or states. And that, I think, gives us a possibility to keep up with the situation. At the moment, 70% of the intensive care beds in Germany are used. So there is still a perspective to work with this uptick. But what we at least fear is that this development could reach a point where it is difficult to keep up, especially regarding the possibility to have enough employees to work on.
From what you've both described, it sounds as if there's really a dual challenge, right? One is to have enough intensive care units, and the other is to have the staff that can manage those units. Of course, in Germany as well, Germany's been able to offer some of its ICU beds to patients from neighboring countries. And I guess the question that I would have for you, Dr. Nagel, is how much longer do you think that might be the case?
Well, I don't see that there's a change in that strategy. I think it was always important for us as Europeans to really support France or Italy or Spain with intensive care units. In March, April, and May, we did not have any problems with that. Here in our hospital, we had about 15 patients from France, and that was very important for us as city, as a cooperation city, to Strasbourg, to really support Strasbourg citizens. And we still do so. But what we at least at the moment see is that the numbers of cases, for example, in France are reducing due to a lockdown over the last 3 weeks. And the same can be seen in Spain. So at least what we feel is that we are on the top of a wave, but we are slowing down again through decisions made by our governments to really reduce contact again. And at least I personally don't see a negative development in that way, that our hospitals would stop, for example, to take patients from other countries.
Thank you. In your comments so far, you've both talked a little bit about how the kind of care that's been provided has changed a little bit between March and now, as we've learned more about COVID-19 and about how to treat it. I'd like to maybe ask each of you to comment on how change for COVID patients has evolved since the early phase of the pandemic, and what might be contributing to lower mortality rates. Dr. Rich, would you like to start with that?
Yeah, again, it sort of goes to a night and day metaphor again. In March, the disease ran rampant through nursing homes, and we had not yet figured out how to protect our elders, probably because there was so much community spread at that time that the people that worked in the nursing homes were spreading the disease. And so there was a huge amount of death related to the extreme elderly and debilitated population in nursing homes. Hardening that has made a difference. And we only saw about a 4 or 5 year change in the average age in the hospital, but I think it reflects that. Second, and very important, is that we had so little capacity with the massive wave in New York in March and April that we told everyone with mild and moderate symptoms, stay home. Don't even come here. Don't even get tested. We just don't have the resources to help you. Only come if you're on death's door, effectively. And so therefore the people that were showing up were very far along in the disease process, usually day 8 to 13 of disease, and when people would develop lung complications, and getting away from just how we learned how to better deal with oxygenation. I think that that's another key issue. And now when we bring people in earlier, we can be working with people during the viral replication phase of the illness, as opposed to the second phase, which is more based upon some kind of immune dysfunction. I certainly don't want to say cytokine storm, because I think that was over pushed in the early phase of that. So we bring people in now ambulatory, and although it's limited, we're giving them the Lilly and the Regeneron monoclonal antibody products. We just started that this week. We still have the Regeneron trial for people who are less ill, because the EUA for antibodies is only for those who are have a lot of underlying conditions which portend a bad outcome. Then in the hospital, we have convalescent plasma, which is a very imperfect therapy, but probably a quarter to a third of the units we give are relatively high titer. And if we screen people and they're not yet creating their own antibodies, it may be beneficial. And there's some, there's anecdotal, not anecdotal, I'd say there's cohort data that suggested, although the prospective trials are just nowhere right now in terms of anything definitive, but they'll probably be supplanted by hyperimmune globulins or monoclonal antibodies for early disease treatment at some point, but just very early. And then later in the course of care, a combination of glucocorticoids, steroids, and also don't ever forget about anticoagulants, blood thinners, drugs that prevent clotting, because we saw so many deaths in the early phases of the disease that were related to endothelial damage in heart, and also in lung, of course, and in brain, actually less so in kidney. So as we learn more about the organ dysfunction, I think the therapeutics have evolved, and I would just want everyone to take away from this the idea that there are 3 phases of care: pre-hospital, early hospital, and later hospital. And so that's, I think, how the treatment paradigms are starting to gel.
Professor Dr. Nagel, you'd probably agree about those 3 phases of care that Dr. Rich just described. Sorry, go ahead.
Absolutely. And I think what is pretty obvious in this discussion is that we have a worldwide development of the treatment of patients. And one of the major abilities we have to cope with this pandemic is that we, in this international conversation, develop our treatments and as well as new medications. For example, about anticoagulation therapy, regarding the question of corticosteroids, regarding new treatment perspectives in terms of oxygenation, ventilation, etc. So that is very similar to what Professor just said. My question actually is, when you were talking about Germany and that we did cope quite well with this pandemic situation in general, what we still can see is that in terms of mortality rate, Germany is one of the countries with the lowest mortality rates in the world. And for our discussion, I looked up the mortality rates between Germany and the US, and you can see that in Germany, it's about 30% lower in terms of the numbers of patients. And that is certainly not related to the intensive care treatment or to the treatment Dr. Reich just said. And therefore, I think there do arise some questions how the difference can be explained. And one of the differences I personally see is that we certainly have maybe we have a different situation in the general health of our population. And it might be that for whatever reasons, we in Germany have done at least more, or given more attention to protect our vulnerable groups and their general health situation. So in terms of who is endangered to become an infection, that percentage might be lower in a population in Germany than in the US. And that could be one of the reasons why we see that you have a higher rate of mortality than we in Germany. So it comes from the hospital care perspective to the public health perspective, if one discusses the situations we are facing.
Maybe just a quick footnote before I hand over to Katja, who I know has some questions, but I think your comment about maybe a difference in the general health of the population is a good one, but I would go so far as to say in the general health system between Germany and the United States. Certainly during the years that I lived in Germany, I found that there was much more of a focus on preventative medicine than I've sometimes found in the US, where it tends to be more an emergency that brings you to the doctor or to the hospital. And so through prevention and early prevention, one's maybe more used to going to the doctor when one has some of those early symptoms than might be the case here in the US.
Well, I totally agree. And that might be one of the explanations, that the access to health services is much more easier for citizens in Germany than in the US. And people are more used to that regardless their insurance status. And that could lend to the suspect that comorbidities are treated better, and so the impact is lower on the mortality rate. I always wondered, if you look at the WHO data, and for example, the mortality risk for heart attacks in US and Germany, Germany is always not doing so well at the US. And I never did understood it unless I explained it by the situation that the US healthcare system, or especially the medicine level, is an excellent one. But if I now look at the data, I think maybe this is only referred to those who come to the hospital, and it is declined who is not reaching the hospital. So the mortality rate in the US on heart attacks could be higher than in Germany. Even the WHO reports that the in-hospital treatment is better than in Germany, because in Germany, everyone comes to the hospital, but in the US, it might be that only those who can afford it come to the hospital. So that might be one of the explanations that we can now see in the pandemic situation, where everyone is registered.
Mm-hmm.
I think it bears agreement and setting just a slightly different perspective with Professor Dr. Nagel, in saying that the social determinants of health are extremely important. And so the socioeconomic status in a city like New York, which has a high proportion of people of a non-white race and ethnicity and poor access to healthcare, is certainly a driver of outcomes. And I'm no apologist for the current mess of a U.S. healthcare system in terms of insurance coverage, but suffice it to say that I believe that there is no doubt that having a better approach to population health sets up a nation to have a lower rate of complications from COVID. But these are very long-term issues that we all have to address as societies, and all of us are on a pathway towards continually trying to improve it. Just watching what was happening in recent years with crises related to refugees from different parts of the world coming into Europe, all of us have to confront what it means to have waves of people coming to our nations who just don't have the same access. And even if there is a national health program, people who have language barriers or technology barriers do not really have the same level of access. And that's always going to be something we have to work on. And it's very important in the COVID era too. I'm very concerned right now with antibodies therapies coming out that it doesn't just go to well-insured people who are well connected to the health system. We have to try very hard to make sure that all of the members of our community, irrespective of their insurance status, have equal access to a very limited supply.
Yes, thank you very much. So before we switch gears a little bit, we just have one viewer question, and that is, Dr. Rich, you just said in the US, we see different survival statistics and the pandemic plays differently out by race and ethnic background. Mm-hmm. So the question is, Dr. Nagel, do we see something similar in Germany? Is there statistics that proves that the pandemic plays out differently for people with coming from different backgrounds?
Well, no, we don't have that data at the moment. I think because the groups are not as large as we have seen them in the States. We certainly in the beginning had a very high impact as well as the US to those who are living in elderly homes, and certainly those who are living in elderly homes are in general are related to a lower social income group, but we don't have any major difference in terms of migrants or other ethnic differentiations. There's no data on that so far.
So I would like to ask both of you, as we see this uptick in cases and hospitalizations and not necessarily mortality rate, and Dr. Rich, you already deplored policy shortcomings with the medical profession being at the end of the line. Everybody in the hospitals might at some point with the exponential growth of cases and hospitalizations face very difficult ethical questions when it comes to who is going to get the treatment and who might have to be denied the treatment. What is it that hospitals provide their staff with? Is there any guidance given by hospitals? Is there any guidance coming from the policy sector? How do you prepare for these scenarios when you can just imagine that the medical personnel might just be overwhelmed on the spot to make these kind of critical decisions? And Dr. Nagel, I know you've served on the German Ethics Council. So has this been discussed, and how do you tackle questions like this, almost impossible questions like this?
I'll be happy to start. One of the things that we talked about in March, as part of our scenario planning, is what crisis standards of care look like. And that is, there is a field of study related to that in disaster management. And I believe very strongly that even during the worst of the surge that we saw in March and April, that we use the same principles And we never ran out of ventilators. We never ran out of ICU beds, although we doubled people up and had 2 patients in a single ICU room to enhance capacity. So I don't think those issues were approached, but it was very important that as a society that we continue to grow in our understanding of goals of care discussions and palliative care. So if we have someone in their 90s with COVID and renal failure and severe coronary disease, it's pretty clear that the individual has a remarkably high risk of mortality. And so working with patients and families that goals of care discussions that would have happened under a non-crisis situation, I believe were generally applied in exactly the same fashion. So we did have palliative care as part of the process of managing hospitalized patients with COVID. All of that being said, I believe that it's incumbent upon us as a society to be sure that the old or the poor or the otherwise disenfranchised are treated fairly in the medical profession. And so I think we work hard to overcome the barriers to access. But I firmly believe that it's okay to talk about how you would apply crisis standards of care. I think it's fine to model them out. It's fine to have ethical discussions, but hopefully it only ever becomes a last resort in those sorts of circumstances. And I really don't believe that even with the severity of the crisis that we reach that point.
Do you think, and just to follow up with that, do you think in New York the first responders are in a situation to handle an uptick as well?
I'm sorry, could you repeat that? I couldn't hear.
I was just wondering, you were talking about access to the hospitals and the care you provide in hospitals. I have these images in mind that flash over the news, of course, with the first responders being out in New York and going to patients' homes. First responders also, are there enough basically to handle an uptick too?
Yeah. I think that a city like New York, I can't speak to the entire nation, but a city like New York has a very well established emergency medical transport system. And so you call a single number in the US, it's 911, and an ambulance will be sent anywhere in the city of New York, and all of the surrounding region has similar processes, and you will be brought to the nearest hospital that is able to manage your situation. So that part of the system was fine. I think the challenge was that many of the first responders developed COVID because we all had to learn how to use PPE properly. And there are circumstances such as when you begin a resuscitation or an intubation where there's a lot of aerosolization, and not everyone, had the right equipment initially. I think that's improved over time, but we're very much looking forward to seeing the first emergency use authorizations in the US for vaccines so that we can begin to offer that to first responders and to the medical profession, because one of the challenges in providing the care, you talked about shortages of staff. Well, some of the shortage of staff is related to staff coming down with COVID and being out of commission for days or weeks. So that's it's part of the process that we have to look forward to and manage well through the winter.
Yeah, thank you. Dr. Nagel, I know in Europe, Boris Johnson, he warned his population saying that, we might come to the point again where we face these difficult ethical questions. In Germany, the situation might be a little different. What can you share on this matter?
Well, I think certainly it depends on the situation in different countries. If you look, for example, on the number of intensive care beds, we have about 30 to 100,000 people in Germany, and you have about 7 in UK. So it's certainly pretty clear that you come to a more difficult situation in a country where you don't provide as much medical care as you provided, for example, in our country. But nevertheless, we have intense discussion about the resource scarcity in healthcare in Germany as well. Even we have from our legislation perspective where we would say this should never happen. You have a right of healthcare and you have a right to be treated. But as Dr. Reich already said, that is not the reality. And we overall, in the terms of organ donation, organ education, etc., have this discussion. What are fair principles to take into account? What is the reality of a patient, who should be served first, etc. And in this discussion, that is one of the reasons why we have a governmental ethical board for the living science. That is one of the questions where we search towards clear criteria. And that obviously is difficult in a situation like we have now in the pandemics. What is pretty clear is that doctors do not want to decide on their own, and that it's a needed public debate before we have a decision. And therefore we had, for example, in terms of the question who is going, the first group who receives vaccination, we have now a declaration of Leopoldina, which is the highest academic board in Germany, together with the German Ethical Council, to open up a public debate regarding how are we going to organize the situation of vaccination when it starts. And it's pretty clear that we not only look towards the question of organ failure or specific disease situations, but also look how we can maximize to save lives, how we can save quality in these life and in the life years, quality adjusted life years, and certainly the probability of a successful treatment. And these are the indications which we think are important to quantify. And why do we quantify it? I think because you don't have a qualitative differentiation between personal living situations. So therefore you try to bring it down, even it is always a construction, you try to bring it down to a situation where you can measure the reason why would one be preferred in terms of treatment. One of these measurements is age. And we have an intensive debate on the question, should age be a differentiation in terms of providing treatment if there is a resource scarcity? And we denied it for our country. We have said, no, age should not be a differentiation criteria, even it is an objective, as I would say. But in our understanding of our society, we have denied that. So therefore, we are now again searching on more medical-based criteria, who has better chances, who has better outcomes, which again is a difficult question. But what we try at least is to support our system with overall criteria. As an example, we have for the intensive care units a triage score, who is related to the organ as a sequential organ failure assessment. It's probably in the same in the US, the SOFA score. And that, for example, is one of the basis to make decisions in terms of a shortage situation. So far, we don't have one, but at least we have a perspective how to deal with it if it comes to that situation.
Okay, so before we switch, you both mentioned vaccines already, and everybody, of course, I think our viewers are very excited. So with the latest news on the vaccines, we have one quick viewer question, and that is, the better preparedness, is that also due because of contact tracing? Is that part of, from a medical perspective, does that figure into your assessment of being better prepared with the pandemic and being better prepared from a medical perspective? Just a very quick 1 minute, and then we go to vaccines.
I'll say very quickly that testing in the U.S. has been problematic. It probably is a worldwide issue. The supply chain, and from everything from swabs to plastic containers to reagents to run large platforms, and frankly the poor quality of many of the point of care tests has made it challenging. Sometimes the turnaround time has been days rather than hours. And so if you take into account testing limitations, that's one barrier to good contact tracing. The second is that the US is a funny little healthcare system of 50 independent states that have their own health departments. And within those states, they have different counties, and those counties have their own health departments. And so what it means is that you have to have a perfect alignment of the stars to have good testing, a competent local public health authorities, and then the final ingredient is a population that's willing to deal with it. If you happen to be running a university with a bunch of 18 to 22-year-olds, good luck, because they're just inherently poorly behaved. But disparaging youth aside for the moment, I think the point is that it is a complex interplay between the ability of testing, the competence of local health officials, and frankly, the compliance of a population and the messaging that they get from their leaders.
Well, we in Germany have we actually have the same situation regarding the federal structure of our healthcare system, because those who are in charge for decision regarding the hospital is the local administrator. Even we try to really bring all the federal state approaches together. It's still the local governor who's then deciding about the healthcare situation. Nevertheless, testing has been an important discussion in Germany too, and we have different situations in those areas, like here in Bavaria, where we had the highest numbers of COVID infections in the total of Germany. We are the most intense testing region, which gives us some sort of security to deal even with the higher numbers, but it does not decline the numbers of infections. So that at least you have to acknowledge. Nevertheless, I'm very much in favor of testing, and we run our university, Dr. Rich, with this 18 to 24-year-olds with a very hard testing strategy, so we can have the classes ongoing, and everyone who has difficulties has to be tested. And well, you certainly have to acknowledge that you want to do it, but that gives us a security that we can go on. A lot of other universities have closed down and just have changed to Zoom because they could not provide the testing capacities. Even that shouldn't be a problem at the moment anymore, at least here.
As Katja mentioned, we definitely want to talk about vaccines. And as we've all learned in recent days, BioNTech and Pfizer, Moderna, and now also AstraZeneca, together with the University of Oxford, have developed what would appear to be effective vaccines. This is obviously good news, but one of the next real challenges is going to be the production and distribution of the vaccine. What does a vaccine on the horizon mean for the midterm in the hospitals that you both run? Dr. Rich, why don't we start with you?
Well, for the midterm, or really short, I'll start with short term. If we have an emergency use authorization sometime in December and dissemination of the mRNA viruses of probably at least one, it looks like the leader right now is likely to be Pfizer, but and we can get our staff to agree to come and take this, barely out of experimental therapy, and come back 3 weeks later for the second shot. I think the promise is that some of the healthcare, patient to healthcare worker transmission and healthcare worker to patient transmission chain will be broken by a local herd immunity at the healthcare provider level. And so I think the promise for the winter is that a sufficient number of our staff will cooperate with that. But there is a lot of vaccine reluctance related to the newness of this. There are cultural barriers to vaccine in the US, for example. Most of the people that work in our food services and environmental services areas are people of lower educational status. Many of them are Black and Latinx. And because of various reasons, including the history in the US of horrendous research, many individuals of color are very suspicious of the healthcare industry, very suspicious of vaccines. So overcoming vaccine reluctance is going to be a problem throughout. But I think the near-term hope is that healthcare workers and first responders should hopefully become less ill, so that hardens the workforce a bit, assuming the vaccines prove to be effective in real-life use, as opposed to large but still small sample studies compared to the massive size of the population.
Well, over in Europe, I think we have a different situation in Germany regarding the reluctance to vaccination. About 80% of the population is positive towards vaccination. Even we don't have any areas except measles, who now for the last year became a duty to in childcare. And hepatitis in our hospitals. But other than that, it's an open decision, or it's a free decision. And that will be the same for the COVID vaccination. That has been a very intense discussion again. Should that be demanded? Should it be demanded for a specific area? And that has been denied. If we now talk about specific areas, for example, the airlines who demand a vaccination to transport someone, we again have an intense debate. So the reluctance could be increasing by the situation that there might be a duty to take a chance to become vaccinated. If that is not the case, I don't see major problems. Nevertheless, we have situations where this will not change in our hospitals over the next few months in general, the situation, because it will take a longer period of time before the broader population can be treated. And again, I truly hope, and I'm convinced that we don't see any major complications. But nevertheless, as we know, in this situation where we have this very high sensitivity towards probably complications through the vaccine, we have to be very careful to go step by step. So I'm very much looking forward to the possibility. I'm encouraged by the results we have seen, but nevertheless, it's not a solution. And I think that is very important, that we could not come out and say, well, it has been a very difficult time. It will end in the end of this year because we have vaccination possibility and now everything is solved. That will be not the case.
Thank you very much. So this all sounds very promising, and since we already talked about how much better hospitals are prepared now compared to the situation in March, and the fact that we have vaccines, we have antibody treatments that are just waiting or have already gone through emergency authorization. When you look at the big picture, what are the lessons that we can draw from the current crisis that will help us be in a better position to prepare and manage a next pandemic? Not that we want to think about that, but it looks like this was this fairly new for all of us. And is there anything we can draw for preparedness, emergency plans for the future? And I don't know who want to start.
First of all, I'll say that I wouldn't want the message to get out to the group that we're out of the woods with vaccines and antibody therapies, because the amount of antibody therapy that's produced in the US so far is barely more for the end of the year than the number of new cases that are diagnosed in a single day. So it's a tiny fraction of its potential use of the potentially useful patient sample to receive it. And vaccines, if they do come out at the end of this year, will once again be, not even 5% of the U.S. population. So we're not really there, but there is promise, of course, that over the course of 21, that we will start to see enough availability. But I think that there has been I don't think it's definitely documented that there's been an underinvestment in pandemic and other disaster preparedness at the government level. And I think that one of the things that could come out of this crisis is that there's enough of a worldwide shock that governments, when it comes time to prioritize and decide what gets in the budget and what doesn't get in the budget, that pandemic preparedness will become a higher priority item, at least for a decade or so, I imagine, just with the memory of the COVID pandemic.
Yeah, I would like to just continue in my first sentence, that I would say we have now made quite a lot of new, or we got new views on the situation we are living in. And I think it's very important that our considerations to help to prepare a better healthcare system, as well as in Germany, as I think worldwide, should not be forgotten after the pandemic. I mean, you just said, well, we look forward to this pandemic, but that's pretty obvious that we, for example, have seen in Germany that we forgot, for example, about the public health services. We have now decided to increase and to invest in infrastructure and digitization. But before 2020, we just cut down in that area. And also, I think what we discussed intensively, that we may not need so many beds in comparison to other countries, what I just mentioned before, the relation of beds to the inhabitants in Germany versus other European countries. Now, I think that has changed. We have seen that we can afford these areas of healthcare management, but we really have to support it with staff. We have to support it with education. And certainly we have also changed our view on the economics. I think what in the beginning of this pandemic, we have simply seen that special goods, for example, protective material, breathing masks, disinfection, is not produced anymore in Europe. We weren't able to really keep up with that, and had to see that under globalization aspects of economics, we were not prepared for those limitations. And I think all those different fields have really been viewed new through this situation. And so on the one hand side, the healthcare system, on the other hand, the way of organizing our economic structures have to be reviewed. And I hope we don't forget what now seems to be pretty obvious.
So, Dr. Rich, you were talking about the fact that we're going to have to deal with this well into 2021. And before we went live and got started, Professor Dr. Nagel was talking about this as a period of unprecedented uncertainty. And I guess as we come to a close, obviously this uncertainty will continue into 2021, if not longer. Do either of you have any guidance for our viewers on how to manage this uncertainty?
I think the most important initial guidance is to remember that public health measures work. And to the extent that we can maintain public health measures, avoid pandemic fatigue, work with different populations such as university campuses, as I alluded to before, and understand that vaccines probably don't become a real public health measure until the middle of 21. I think we can reduce a tremendous amount of death and suffering and prolonged illness, because there's a certain portion of patients that when they recover from COVID seem to develop a post-viral syndrome, which can be debilitating, maybe as little as 1%, but still a lot of people when you look at the scope of this pandemic. So I think the message that I would send out to everyone is, don't forget about public health measures. It is too soon to really count upon the therapeutics, including the vaccines, to save us, from excessive death within our communities. And so therefore we have to hold strong and be good advocates as healthcare providers, that everyone act responsibly, because responsible members of society protect one another.
Yeah, and I could continue in the same manner, and what Dr. Reich said, again, the view that the pandemic really taught us in a global world what it means to really take care about public health perspectives, and that there is a recurring danger of any source of not only a pandemic but other catastrophe situations, that can, and it can be of advantage that we really on a global scale have a certain reserve capacity available in terms of dealing with such a situation. And therefore I'm really looking forward to intense or a continuation of our intense multilateral cooperation in terms of research, as well as the treatment of those who are endangered.
I think it's fair enough to repeat, we're not out of the woods, but certainly there seems to be a light at the end of the tunnel. If I may sum it up, you certainly reported about some promising improvements, and I think we have all the trust in the medical care that you deserve. At the same time, we're hopefully vigilant to make it through this together. So thank you so much, Dr. Rich and Dr. Nagel, for taking your time during your very busy schedules during this crisis right now. This was a great discussion, and we've really enjoyed it immensely. We've learned a lot. On behalf of 1014 and the American Council on Germany, thank you so much.
Thank you for inviting us to participate. It was a great discussion.
I always really enjoyed to be part of this, and thank you, and all the best to you, Dr. Reich, and the Mount Sinai, as well as to the American Council and 1014.
Yeah, and I can't wait until the day when we can all travel again and I can come to Bayreuth and see a concert.
I really invite you to come. We had the first time since 100 years that the Wagner Festival could not be conducted, but we look forward to do it in 2021.
Very good. Thank you.
Well, I just want to add my thanks to both of you. Hopefully we'll emerge from this crisis better prepared for the next crisis. I also want to thank our viewers for participating today with your questions, and wish everybody well during this pandemic. For our viewers in the US, of course, a happy Thanksgiving, and our viewers in Germany, a schöne Adventszeit. Until the next time, stay well, everybody.